Okay, I think already I myself covered IVF stimulation protocols, I think. But few things again I'll repeat. If you're having doubts, you just let me know, all of you. Okay? The introduction is the first IVF baby was born during a natural, unstimulated IVF cycle. However, the success rates using this method were low, mainly due to retrieval of only a single oocyte. Hence, the use of ovarian stimulation protocols were developed to achieve synchronous development of multiple follicles and to enable retrieval of multiple oocytes, resulting in an increase of success rate. So important thing is when we are doing ovarian stimulation, synchronous growth is very important to have like little bit extra amount of oocytes and extra amount of embryo, which leads to. So with increasing use of stimulation in IVF cycles, the problem of premature luteinization with significantly impaired success rates was recognized. With natural cycles, ovulation could occur at any time of the day or night, requiring oocyte retrieval at inconvenient times. Nowadays, majority of IVF cycles are stimulated cycles and various protocols have been developed to deal with the above problems. So if it's a natural cycle, at any time it might ovulate, so we can't do pick up at midnight. So for that, we will be mostly giving the triggers around after 10 o'clock and accordingly plan after 35 to 36 hours around morning clock onwards, we'll start the pickup. So for that, for all feasibility things also, we started going for the stimulation protocols. So objectives of stimulation protocols in IVF cycles: obtain synchronous development of a cohort of pre-adrenal follicles in the ovaries to prevent premature luteinization, to control the timing of ovulation so that the oocytes can be surgically retrieved prior to the ovulation. So the hormone dynamics, which are here the FSH and LH are very important. Okay. And I think this slide last time also I have showed you with the hormones things. I think you all can take a picture of this slide. It will be easy for you during your ovarian stimulation protocols. Okay. Uh, the next important thing is a threshold theory. When the FSH level is above the threshold, a follicle will be rescued. So the threshold will be more, should be more than the like a certain amount. Then only we will have multiple follicles like to grow when we are doing the ovulation, I mean like ovarian stimulation. So FSH threshold and window concept. Each arrow represents a developing follicle. FSH window by administering FSH in the mid-follicular phase to maintain FSH levels above the threshold, allowing the multifollicular development. So if continuously, if you are giving FSH throughout, which is above the threshold level, then we have multiple growth of follicles. Normally in our if it is a natural cycle, only one follicle will be growing. But in IVF cycles, we need more than one follicle to have multiple embryos. So the threshold should be higher and continuously FSH should be, I mean, it should be given continuously to have a multiple follicular growth. And LH window. So if the LH is less on the lower side, impaired follicular growth, impaired oocyte maturation, inadequate androgen and estrogen synthesis will be seen. If it is high, there will be a follicular atresia, oocyte development compromised, suppression of the granulosa cell proliferation, and premature luteinization. So we need an optimal level of LH so that the follicles grow properly. So the optimal level will be between 1.2 to 5 international units, the LH. So optimal level for optimal follicular development level should be above the threshold but below the ceiling. Okay. And successful stimulation regime. FSH window above the threshold for suitable time to get good number of follicles. How to fulfill it means how to do to get these multiple follicles is by giving from outside this HMG or FSH, which whether it's a urinary component or a recombinant. From outside, if you are giving continuously these gonadotrophins, there will be multiple follicles. And prevention of premature LH surge. So it should not be a premature LH surge. If there is a premature LH surge, there will be a ovulation, which we don't want before the follicles are very less. And for that, what we should do is we should give either agonist, we should go through either agonist protocols or the antagonist protocols. And follicular bar oocyte maturation, how it does, like by giving from outside the HCG triggers or the loop right triggers, which have both the HCG and LH. And next are the luteal supports, exogenous progesterone and estrogen. So main protocols what we are having is GnRH antagonist protocols and GnRH agonist protocols. Previously, it used to be every time everyone used to use this GnRH agonist protocols. From recent, like past 10 years, we started using these GnRH antagonist protocols to minimize this OHSS, because whoever we are doing these agonist protocols, there are chances of OHSS in patients. We should give here agonist protocols only HCG trigger. In the antagonist protocols, what is the main thing is we can give agonist triggers also. For that, OHSS risk has completely come down to less than 1% or very negligible. We very rarely see this OHSS patients. So differences between GnRH antagonist and agonist. Receptor blockage without receptor activation, competitive inhibition, immediate and dose dependent suppression. It will be an immediate thing, because after giving the antagonist in mid-cycle, no, there will be suppression of LH and there will not be any rupture or premature rupture of or ovulation will not be there, and rapid reversibility will be there. And in the GnR agonist protocols, receptor downregulation, pituitary desensitization, initial flare-up, slow reversibility. Next, so what are the gonadotropin preparations? One is HMG, which contains 75 international units of FSH and 75 international units of LH. Okay, and highly purified HMG also has FSH and LH. And urinary, only specifically we have FSH. And specifically I mean like purified, highly purified urinary FSH, highly purified again urine FSH, like how I told, and recombinant FSH. Nowadays, like new drugs have come up are like RFSH, recombinant FSH, and RLH also, recombinant LH. And together we have in few drugs named Pergoveris. So if we give whoever is having polymorphisms, all those patients, no, we start with high doses of recombinant FSH and recombinant LH instead of giving this urinary or highly purified. Okay. So which is better? That is the thing. So protocols, many protocols are there. They are natural protocols, minimal stimulation protocols, mild and aggressive. GnRH agonists can be combined with only aggressive protocols, because agonist protocols are like we are first suppressing everything, the pituitary, then we are again starting the stimulation. So which is already suppressed, to properly grow the follicles, we need little bit aggressive treatments, means high doses of FSH and LH are very much needed. Coming to the GnRH antagonist can be combined with all of this, anything. It can be like low dose also we can start in the GnRH antagonist. In natural also, if the follicle is around 60 or 14 or anything, if it might rupture, we might think when it is 14 only, when the E2 levels are more than 200, we can start this antag so that it will suppress the LH levels and we can grow the follicle to the desired size, like around 18 to 20 mm. Then we can go on for, we can give the trigger and go for the pickup. So ideal ovarian stimulation regime for IVF criteria. Look, so these all things, these all criteria should fit into this to start the stimulations. First thing is a very low cancellation rate. Whenever we are choosing a protocol, it should have a low cancellation rate, minimum drug cost, minimum risks and side effects, require limited monitoring, maximize singleton pregnancy rates. So types of ovarian stimulation for IVF. So natural, same I already told you, modified natural, mild and conventional. Previously natural, what we used to call is unstimulated spontaneous cycle. Modified is semi-natural, controlled natural IVF. Mild is soft, minimal stimulation, friendly IVF. Conventional is standard, routine, controlled ovarian stimulation. Aim of natural is a single oocyte. Even modified is a single oocyte. Mild is like approximate 2 to 7 oocytes. Conventional is more than 8 oocytes. Methods are in natural, no medication; in modified, only HCG trigger. And I already described, if the follicle is around 14 mm, if the E2 levels are a little bit on the higher side, it's better you give the GnRH antag so that it will suppress the LH and there will not be a premature ovulation. And with mild low dose of FSH or HMG, oral compounds also sometimes we may use, and GnRH antagonist. In conventional, we use both the things. Agonist protocols we can use, antagonist protocols, along with the conventional FSH and HMG doses. So main protocols, already it was divided. So GnRH agonist protocols, GnRH antagonist protocols, and no GnRH analogs. Means in GnRH agonist protocols, there are different types of protocols. What are they? Long, short, ultra short. And coming to the antagonist, they are standard. Standard means normally we give dosage. Mild means very less dosage. Modified natural means we start already like normal cycle, natural cycle, we start giving some extra dosages. Like one follicle is there already discussed. In between, we'll start the antagonist so that to suppress the LH, and no GnRH analogs. Without giving any analogs, naturally every month for females, we'll have a one follicle growing. That thing we will be monitoring. That's all. So optimizing ovarian stimulation, the response to the ovarian stimulation depends upon the number of recruitable follicles in the ovaries, the bioavailability of FSH, the sensitivity of recruitable follicles to FSH. Best results can be obtained by personalizing the protocol, clinical ultrasound and endocrine investigations, using the optimal starting gonadotropin dose, predictive factors and models, manipulating the FSH dose according to the response. So natural cycle. So in natural cycle, I already told you last time also, there is no stimulation. We just do basal blood test, some endocrine test and ovarian reserve test we will do, and we will directly call the patient. We already knew what is the cycle length of the patient. So for sure, we will know what is the follicular phase and what is the luteal phase. Depends on that. On day 9 of the cycle, we call for the follicular monitoring and we do some blood test. And if the follicle is more than 14 mm, we just monitor again properly. It is because as this is a natural, we don't give any other things like any like for suppression antagonist we don't give. We just check kits to detect the urinary LH every 4 hours. When the LH is positive, OPU after that for 36 hours. Most cycle cancel due to inability to retrieve the oocytes, and the success rates for the natural cycle will be obviously on the lesser side, which is less than 7%. So here, same, the FSH window concept, it just raises. So we have a one single monofollicular development will be there. But if it excludes, exceeding the threshold levels, then we have multiple follicles. So candidates for this natural cycle is women who respond poorly to the ovarian stimulation. Sometimes very poor ovarian reserve with 1 or 2 AFC patients, continuously if you are giving gonadotrophins also, they will not respond. For those patients, each and every follicle is important. As they are having already natural cycles, we just can follow up their natural cycle and can pick up the egg. Women who respond poorly to the ovarian stimulation, women with Dr. Manisha, can you put your thing on the mute mic? Dr. Manisha? Rajana, can you put the mic on like mute? Women with medical conditions, some patients who are having some breast cancers or anything also, for them, estradiol level should not to the higher side. For all those patients also we prefer. And disadvantages are high cycle cancellation rates and low success rates, no opportunity to select or cryopreserve embryo. Advantages are very low cost, minimal risk and side effects, and minimal monitoring. No control, and the problems are no control over ovulation, no control over the cycles, not possible to batch, and few centers have batch IVFs. So this is not at all possible for these patients, and less success rates. Next comes the modified natural cycle. Here, what we do is same. We will monitor the follicle, everything. Like how I told, we can in between when it is around 13 to 14 mm, we can start this end tag, or if it is not growing properly, we can add some HMG or FSH. When the follicle is around 18 mm, then we can give the HCG treatment and go for a pickup around 35 to 36 hours. Okay, still success rate is around 14%. For natural cycle, it is around 7%. One follicle, one oocyte, one embryo here also. Same for the poor ovarian reserve patients, we do all these things. Conventional ART, single embryo transfer success rates around 35 to 40%. Until if we get a good blast, there is a success rate of this much. Otherwise, normally it will be around 14%. There we do single best embryo transfer. In modified natural cycles, we do single available embryo transfer. Same indications are very already I have told, very poor ovarian reserve, any contraindication for the stimulation because E2 dependent malignancies. That is the thing. and minimal stimulation. And next comes modified. After modified, this is a minimal stimulation and mild stimulation. Here we can start using the clomiphene citrate 100 mg from day 2 to day 5 for few days, and letrozole also we can use. Okay, and all these things we'll be using along with the FSH and LH, means FSH and HMG drugs. Only difference is follicle number and the oocyte yield. One follicle we see in the natural cycle, 2 to 3 follicles in the minimal stimulation, 4 to 5 follicles in the mild stimulation, the success rates. And coming to the concept of mild ART, moderate and continued elevation of FSH will be there, mid to late follicular phase, to extend the FSH window, to overcome the single dominant follicle selection, to grow several follicles. Indications for whom we see is in patient, especially with male factor, tubal factor, all this mild stimulation for poor ovarian reserve, history of OHSS. If the patient is having previous history of OHSS, it's simply giving higher doses. It's not good because they might land in OHSS. For them, you give small doses, slowly you can increase so that you will have certain amounts which is less than 8 follicles, and their chances of OHSS also will be on the lesser side. No facility to cryopreserve. So few hospitals, they don't do the freezing things also. They do a fresh transfer. For those hospitals, this will be very useful. Patient does not want cryopreserve. Some patients don't want a preservation of the embryos. So those patients will do a fresh transfer, obviously, for those patients also. So advantages of mild ART: more receptive embryo will be there, better embryo quality, low cost will be there, less stress to the patient also. Mild versus aggressive. This we see go for the normal reserve patients. Better quality of embryos we get, decreased fertilization failure, pregnancy rates, low pregnancy rate for the mild ART, high pregnancy rates to aggressive stimulation if both methods obtain less than 5 oocytes. See, mild means we get very less embryos or less oocytes. First thing is, if we get less oocytes, obviously there will be a less embryos. So if we are giving aggressive, we get multiple embryos. If one cycle is negative also, next cycle chances of getting pregnancy will be better, so that the pregnancy rates increases. And low oocyte yield, where patients have a very low oocyte yield, in that in aggressive stimulation represents a poor responses. In mild ART represents a normal, response, smoother selection, high quality embryos, stimulate only the most mature follicles. So they are telling in aggressive we have sometimes poor responses, means continuously hitting with high doses of gonadotrophins also. Sometimes the quality of the egg might come down. If we are giving mild stimulation, really what follicles are having proper receptors might grow and we get good output of embryos, they are telling. So mild ART, quality selection among the follicles, avoids forcing poor quality follicles. So in aggressive, we are pushing the poor quality follicles also to grow fastly. So the quality of the egg will be on the lesser side, they are telling. Then decreased pharmacological intervention with physiology better oocytes. Next comes the aggressive stimulation protocols, like how I told are long protocol, means like agonist protocols all come under aggressive stimulation protocols. FSH window in aggressive stimulation protocols, see, this is the normal window. Here, see, it is going like this. From outside, we are giving exogenous HMG and FSH. So this will be for the long duration, because we are giving continuously FSH. So first thing so I'll just directly jump into the protocols. There are multiple protocols we are having. There are long protocol, short protocol, ultra short protocols, antagonist protocols, and random start protocols, luteal phase protocols, double stimulation protocols. There are multiple protocols. Actually, for you, as you're just starting initially, it's better you know few protocols. In that, first very important is the antagonist protocol. Okay, so to prevent OHSS, slowly when you start your practice going on, then you can start doing other protocols which are very useful for the poor ovarian reserve patients. Okay, one thing, directly I'll jump to the protocols for it easy. I'll just show and I'll see. These are the long follicular protocol. This is a long follicular protocol, like already I told you last time. So from previous period, day 1, we start giving patients continuously this is the long follicular protocol, means agonist we start giving from day 1, okay, and continuously we give the agonist daily till 13th day. Then we do the blood test for 2 weeks. After that we do the blood test, then we see the hormone test. If they are normal, then we start gonadotropins and give HCG trigger and do pickup after 35 to 36. See, in the agonist protocols, we are not having any other option. It is the only option which is the HCG trigger, to give trigger. And coming to the long luteal protocol is from previous cycle, when in the luteal phase, we'll start the agonist daily till day 1, day 2 of the next cycle. Again, we'll check the blood test and then again start giving gonadotropins. Again, here also same HCG trigger when the follicle is around 18 mm. And next long follicular depot protocol is same. Previously, what we did is, like in the previous protocol, what we have done is we are giving every day. Here we are giving a like a loop rate depot. Okay, for 14 days we give, and after 13 to 14 days we again check the blood test and again start the gonadotropins. Same again, long luteal. In the luteal phase, you will give the Lupret depot injection, and again after the period day 2 you start gonadotropins. And coming to ultra long protocol, you give this GnRH depot injection, means Lupret depot injection, for at least 3 months, mostly for whom adenomyosis patients or endometriosis patients, or or whoever hormones are on the higher side. For all of them, to reduce their things, hormones we give for 3 months. And again on day 1 or day 2, we just do the blood test and start again gonadotropins. And coming to the GnRH stop protocol, here again, agonist will start from 21st day of the previous cycle. Then we will stop on day 1 of the cycle. We give the patient's blood test. When they are normal, we start the gonadotropins. But in GnRH stop protocol, there are chances of premature LH surge. Why? Because here we are not giving the agonist continuously during the gonadotropins. There might be a chance after giving gonadotropins, the LH might rise, okay, prematurely, and rupture the follicles. So for this protocol, premature ovulation might be there. So accordingly, we should see this and go ahead. And coming to the short flare protocol, here also for minimum days, short flare means first we'll give the OC pills treatment. Then from day 1, we start giving the agonist daily dosages, okay, around 0.5 mg, and continuously along with the gonadotropins, and then give the HCG trigger when the follicles are around 17 to 18 mm, and then do the OPU. This is the short flare. Mostly these all protocols are for the poor ovarian reserve protocols, okay. And ultra short flare, this is also just after period, we after example, the patient got today period. So first 3 to 4 days we give every day 1 mg of loop, right? Along with that, from the next day we start the gonadotropins. Like previously I told you, like stop protocol, this also had chances of premature LH surge. So it's better, we should see and go ahead. In ultra short flare, this is also a stop protocol, and we can convert this ultra short flare protocol into antagonist. How is, first 3-4 days you'll do agonist and then stop, and when the follicle is more than 13 to 14 mm, you will start the antagonist. So in these protocols, we can give agonist trigger and HCG trigger also if it is possible. And then this is a microdose Lupron protocol. This is like the before month, we start with OC pills, and when the patient gets the period, we start with microdose, means 40 micrograms BD. We will start giving the injection, and then after 2 days, we start the gonadotropins, and till the day of trigger, we continue this microdose microdose Lupron. And this is very, very important, which is the easiest protocol for you in your initial stages of practice without any, without any stress, you can do this protocol. Okay, so in this, when a patient gets period day 1, so okay, they'll come day 2, they'll be coming, then you do few blood tests, because normally now there is no role of doing so many blood tests on day 2, but as it is initial stages, it's better you do E2, P4, LH and FSH. And when everything is normal, then you start gonadotropins from day 2 or day 3 of the cycle and give for 3 days or 4 days. After 4th day, you just call for a scan. If the follicle is more than 14 mm, then you can start antag 0.25, which will suppress the LH, so that there will not be a premature rupture of the follicle. So when the follicles, at least 3 of the follicles are more than 16 to 17 mm, you can give a trigger for a safer side. When you are growing ahead and more than 1 year of your practice, you understand each and every cycle. If you are doing only, you'll understand. Then it will be easy when the follicles are around more follicles. We anyways tempt to get more follicles when the follicles are around 10 follicles, around 16 to 17 mm, then you can give a trigger. Till that time, you at least for 3 to 4 follicles are more than 16 to 17 mm, try to give trigger. Whatever follicles you are getting, try to pick up. Okay. And this is mix-up protocol, like agonist and antagonist. So first, what will give? First, contraceptive pills will give. Later on, we'll give leupride again. Lupron will, sorry, leupride or whatever it may be, we will give again. We will stop this, and same I told now, we will continue the follicle stimulating hormone and HMG along with the antagonist. Will give again. We can give their HCG trigger or leupride trigger because we are doing anti cycle again converting. And this luteal phase ovarian stimulation is, see, after the follicle is ruptured, then we can start almost like a random. Same, however, you are giving your dosages of HMG and FSH, will continuously give. And when approximate 18 mm follicle there are, we can see, then you can start giving the trigger. Again, double stimulation is in a same cycle doing 2 times of stimulation. 2 times stimulation means on the follicular phase, and you do pick up, and again start in the luteal phase. One more stimulation you give, and again do the OPU. But with double stimulation nowadays, we are not seeing any double stimulation. They are telling like dual stimulation. You start in the luteal phase, do a pickup, give the agonist trigger, do pickup, and immediately as there is a luteolysis, again within 1 week, 10 days, the patient will get the period. In the follicular phase, you can start again the stimulation, then you give a HCG trigger, and you can do a fresh embryo transfer. These are all new things. So which is very important for you is only the antagonist protocol. It is very important for you. And this is also like what I told, antagonist protocol. In antagonist protocols also, there is fixed protocol and flexible protocol. Fixed no, single dose protocol means only one single dose of cedrolix we will give. Okay, for 96 hours it will be acting. Otherwise, every day 0.2 mg of cedrolix also you can give and continue. And one more protocol is progesterone primer stimulation. So this also, after period, patient will come to you, we'll do the hormone test, and then we start gonadotropins. Along with that, we will give DHEA, progesterone 20 mg per day, we will give, or medroxyprogesterone 10 mg per day till the day of trigger to suppress the LH. Here what? Like it is bypass, like it is an alternative to the leupride and antagonist. Okay. And next, breast cancer patients. For all these patients also, we mostly do antagonist. And as breast cancer patients, E2 level should not be on the lesser side. If you give letrose, starting with letrose will reduce the estrogen levels, so that the estrogen levels will not be on the higher side, but we have proper follicles and do pick up for the breast cancer patients. And conventional start is like same aromatase inhibitors you'll give, and along with the gonadotropins, and again antagonist you'll give and give the trigger and do pick up. And menses falling luteolysis, like how I told you, no, sorry, luteolysis means I told you the dual stimulation. In that, in the previous cycle they will be doing, and then we can start in the next cycle also. Otherwise, if a patient is not having periods, or if she's in a luteal phase, she need to go somewhere, then whenever she comes to you, what you do is you can give this antagonist, this cetrolix 0.25 mg for 3 days. If you give, there will be a luteolysis, and the patient might get period in 1 to 2 days. Then again you can start your antag protocol. This is a random start wherever the patient is. Random start late follicular phase and random start luteal phase. Nowadays, because of so much of competition in the fertility field, we are doing sometimes these random start protocols, which is little bit risky for you people at this stage. So first you learn about the antag. Okay. And one more important slide I wanted to show you is this. the protocol of choice. So for PCOS patient, it's better you do an antagonist protocol. For poor ovarian reservoir patients, you do microdose, short, antag protocol. Also, you can do mild stimulation, long agonist. For endometriosis patient, I already told no depot protocol. So 3 months, you'll give this Lupret depots, and then you start this stimulation, ultra long also. Normal responders, you can do whatever you want, you can do, but make sure you are not landing the patient into OHSS. Sometimes doing long agonist protocols, know what happens, what are small follicles also will come up, and that time there is no choice for us also to give agonist trigger, because for sure agonist for sure these agonist protocols we should give only HCG trigger. So you should be little bit cautious when you are starting the agonist trigger. Properly do a day 2 scan, follicles how many are there, you really check properly, then only if you are very well versed, then start this agonist protocols. Otherwise, which is very safer for you all people in initial stages, is the antagonist protocol. I think it's done. If you're having any doubts, you can directly call me and ask. Any doubts, if you are having, you can just let me know now also. Hi, doctors, any doubts? If you are having doubts, if you are during any stimulation in your practice, you can call Raja Naik. He'll give you my number. You can call me directly so that I can guide you. Not an issue. Okay? Raja Naik, I think I'll close. Dr. Monica will take over. Okay, you want me to repeat the antagonist protocol? Okay, sure. So this is the antagonist protocol. I think who asked me? Dr. Pavani. I think Dr. Pavani. See, antagonist protocol, how it is patient comes to you on day 1 or day 2 of the periods. So when they come on day 1 or day 2, you'll ask them to do this blood test, which FSH, LH, E2, P4. If the E2 is less than 60 mm, sorry, 16, sorry, 60, if the E2 is less than 60 and the follicles all are less than 10, then you can start the stimulation. Okay, if you are able to see any cyst, then for sure it's better initial stages you don't start any stim. Okay, if the E2s are on the lesser side and P4 is also on the less than 1 and your endometrial thickness is less than 6 mm, then you can start from day 2. If your patient is coming in the morning and you get your blood test in within 2 hours, you can start in the afternoon, or in the next day you can start giving FSH around RFSH around 225 international units, or HMG also 150 you can start. Why? Because nowadays sometimes some drugs are not working properly, or initially if you give some LH, no, because of any LH polymorphisms, you get a good output. So we are telling you to start with FSH and LH. Okay. So from day 1 of, see, patients, day 3 of the menstrual cycle will become your day 1 of stimulation cycle. So compulsory after 3 to 4 days of giving the gonadotropins, you call the patient again and repeat the scan. If one follicle or two follicles are above 13 to 14 mm, then immediately you will start this GnRH antagonist, which is 0.2 mg, 25 mg subcutaneous daily till the day of trigger, for not having any LH surge, premature LH surge. This GnRH antagonist will not allow the LH to rise, so that you can protect your follicles. And when your all follicles are around, or at least 3 of the follicles are above 16 to 17 mm, you can give your trigger. Depends on your E2 levels again. On the day of the trigger, if the E2 is more than 3000, better you don't give HCG triggers. In initial stages, again I'm telling, because you are in the starting stage, if it is more than 3000, better don't give any HCG trigger. You give only agonist trigger, which is decapeptyl around 0.2 mg you can give, and then after correctly for 35 to 36 hours you can do the ovum pickup. Okay?
Okay, ma'am.
Pavani, is
Yes,
clear,
ma'am.
Dr. Pavani?
Yes, ma'am. Yes, thank you, ma'am.
Okay,
Yes,
if
yes.
you are still, you
No,
can
no,
ask
it's
Raja
it's
Naik.
clear. It's clear, ma'am. I just wanted like when are we gonna start GnRH antagonist? So you've already the follicle size about 14 mm. We can start giving antagonist continuously till the
Yes,
trigger. Yeah,
otherwise,
yeah.
if you are having still all follicles are around 11 to 12 mm, like around 4 5 follicles, no,
Mm,
it's better you do your E2 levels.
okay.
If 2 and LH, if you are doing, if E2 is more than 400, you think,
Mm,
then again you start without the dominant follicle of 14 mm also, you start up GnRH antagonist
okay.
again here also.
Okay.
Okay?
Yes, ma'am.
Yeah,
Done.
yeah.
Thank you.
Thank
Thank
you.
you.
Thank you so much. Bye.